Thank you very much. I feel happy and privileged to be part of ISA Kerala State Conference. I hope everybody is enjoying the academic program. Getting on to my topic, it's lung protective ventilation and challenges. Being anesthesiologists, we are basically perioperative physicians. When you happen to tackle the respiratory system, be it in the operating theater or in the ICU, we have robust and very meticulous equipments available with us. But can we use the power of ventilation to achieve our targets? Definitely, we don't want to create additional insults by creating harm to the patient's own body. The best solution will be to be smarter, intelligent, and use your resources wisely. When you are stuck with a history of hypoxemia, acute lung injury, you are caught between two confusing targets, whether to maintain the oxygenation or to go for a conservative, rather protective strategy with regard to keeping the lung active. Our mission is to protect just like any warrior or gladiator. Now, let us get into some of the teachings that are given conventionally. Conventionally, in the undergraduate times, we have been taught that the alveoli are like a bunch of grapes. Is that true? No. There are interdependent between the septal walls of adjacent alveoli, be it in the axial, septal, or peripheral. What is the implication? We'll come to that a little while later. Have you thought of the concept of broken lung? When the lung is injured, our strategy should be like a fractured bone getting fixed. It's not like a broken heart. In a fractured long bone, what we do is to align the bones, fix it there, and let the inflammation settle, and the healing happens over a period of time. Until that, you don't disturb the equilibrium. That's all you have to do. And then the favorite question, everybody says ARDS lung is stiff, but the question is whether it is stiff or small. The concept of baby lung comes into picture here. Another big question, why should you always calculate tidal volume according to the actual body weight? You know, the tidal volume, the breathing pattern differs with the change in position, the change in ethnic group, change in age, change in height, etc. But still, conventionally, most anesthesiologists go with a fixed tidal volume according to the measured weight of the patient. Another myth is atelectasis, as we see in the literature under general anesthesia, a myth. There are a good number of radiological evidences, and the concept of atelectasis during general anesthesia is being discussed in the latest literature, and it says atelectasis occurs in the most dependent parts of the lungs of 90% or more of anesthetized patients from the first minutes of anesthesia induction, whether intravenous or inhalational method. So now we have a proven bundle of strategies rather than going in for a low tidal volume strategy alone. It works in bundles. That's how we need to go into the concept called perioperative prophylactic positive pressure ventilation bundle. We'll look into that in detail. Before that, let me introduce some terminology. We know what is polytrauma, that is excessive global or regional lung stress and strain due to delivery of a huge volume of air or gas mixture into the lung. Barotrauma refers to lung injury associated or mediated by increased alveolar pressures. Atelectrauma refers to lung injury resulting from repetitive alveolar opening and closing during mechanical ventilation. Biotrauma refers to mechanical stresses inducing a local inflammatory response that can disseminate systemically, leading to multi-organ failure. RACE refers to repetitive alveolar closure and expansion. VILI refers to ventilator-induced lung injury. Now, what happens in mechanical ventilation? We are all familiar with the biophysical injury leading to volutrauma, barotrauma, atelector trauma, the shear, the overdistension, cyclic stretch, and the changes in intrathoracic pressure leading to increased alveolar capillary permeability, reduced cardiac output, reduced organ perfusion, leading to distal organ dysfunction. But more importantly, we also need to concentrate on the biochemical injury referred to as biotrauma, leading to release of mediators and the changes in the epithelium and interstitium, eventually leading to distal organ dysfunction and multi-organ failure, death. This concept is again illustrated with this graphic where you can find a large distending force causing extreme stress and strain as in volutrauma, barotrauma, or moderate distending force leading to atelector trauma, signaling epithelial and endothelial cell surface, and their inflammatory cascade is activated, leading to biotrauma. Again, the same principles are explained with this diagram. Here you can also find the other aggression factors. Here actually it is designated as major surgery, excessive fluid, sepsis, blood transfusion, etc. Little bit on the pathologic tetrad of ARDS. We know ARDS is characterized by endothelial leakage, the surfactant deactivation, the alveolar edema, recruitment, de-recruitment. And now this is very important, how ventilated induced lung injury is happening. Here you can see the meshwork of alveolar septa, and you can identify area of atelectasis or a collapse of alveoli. Here you can find the stress risers, and the alveoli adjacent to the stress risers eventually succumb to alveolar overdistension, initiating the cascade for biotrauma. So the lung instability with repetitive alveolar collapsing and expansion happens with each breath, and areas of alveoli that are adjacent to the open alveoli remain collapsed throughout the ventilation. So opening and stabilizing the alveoli would prevent the mechanisms of ventilator-induced lung injury. And now who creates the problem? Definitely the pathology, the primary insult behind is definitely one of the cause, say it ARDS. The ventilator-induced lung injury mostly is caused by the clinician, because initial phases we don't recognize the initiation of the inflammatory cascade. The progression of to ARDS is often silent with normal blood gases in the presence of ARDS with unstable alveoli, leading clinicians to believe the lung is fine and there is no need to change to protective mechanical ventilation. As anesthesiologists, let's see what happens during positive pressure ventilation during general anesthetic. The same set of spiraling events happen, and it can initiate ventilator induced lung injury and may eventually lead to um, postoperative pulmonary complications. The literature clearly says that even short-term non-protective mechanical ventilation is shown to promote bronchoalveolar procoagulant and inflammatory changes in patients without pre-existing lung injury, suggesting that mechanical ventilation per se could exert a pro-inflammatory stimulus and could trigger apoptotic cell death in non-injured lungs in the context of major surgery. And now, lung protective ventilation is confined only to lower tidal volumes, because we know that low tidal volume ventilation does promote atelectasis formation by itself. The literature as early as 1963 supports this concept. And now these are the components of lung protective ventilation. You can see the strategy regarding the tidal volume, which will accommodate for volutrauma, barotrauma, the changes application of PEEP during positive pressure ventilation will take care of atelectasis to an extent. Recruitment maneuvers can help us resolve the problems with atelectotrauma, volutrauma, barotrauma. The strategies regarding FiO2, the regarding oxygen toxicity, reducing the hyperoxia can also help in lung protection. And one more point I would like to introduce at this point of our discussion, and that is driving pressure. I hope the postgraduates should be familiar with the concept of driving pressure, and how the concept of driving pressure as a key player evolved. If you look at the literature which appeared in NEJM in 2015, you can find that driving pressure and the survival in ARDS was examined statistically. When they studied the effect of plateau pressure against the mortality, they found that when the plateau pressure goes up, mortality also goes up almost parallelly, right? And when you keep the plateau pressure below 28, for example, and then study the mortality, you expect a flat curve with regard to the mortality, but this was not true. Even when the plateau pressure was kept low, the mortality was found to be high when the plateau pressure was kept high with a lower PEEP. So there is something more to it. So they investigated in detail into that, and they identified one more parameter that is called delta P, or driving pressure. So here you can see in the left half, as the driving pressure is increasing, the mortality is increasing, and on the middle segment, you can see when the driving pressure is high, mortality is high. And now they matched the driving pressure, kept it constant, and studied the mortality, and they found a flat mortality curve, probably indicating that driving pressure is a key player with regard to the mortality following ARDS. So what is driving pressure? Let's take a closer look. This is the difference between the plateau pressure and the positive end expiratory pressure. It is marked here. This is the delta P, or driving pressure. So coming to the equations, driving pressure, plateau pressure minus PEEP. If you look at the compliance, it says it's tidal volume divided by PEEP plateau minus PEEP. So we can as well say that compliance equals tidal volume divided by driving pressure. So now I can also say that driving pressure is tidal volume divided by compliance. And this is one key concept where you can understand that driving pressure actually represents the tidal volume corrected for the patient's respiratory system compliance. Here you can find that what is the effect of driving pressure or delta P. From the PEEP value, when the delta P increases, the respiratory mechanics improve and the curve is in a favorable position in the volume against pressure curve. But beyond a physiological limit, when you increase the delta P or the driving pressure, you find impaired respiratory mechanics, and this is what you need to avoid. You need to limit your driving pressure less than 15 to keep the improved respiratory mechanics. This also leads to the concept of baby lung. Baby lung was originally defined as the fraction of lung parenchyma that still maintains normal inflation after near normal mechanical characteristics. Just remember that baby lung is not an anatomical but a functional entity which changes dimensions and location with prone position and PEEP application. So now the concept of baby lung is evolving. The baby lung is becoming an adult with respect to the evolution of the concept or the clarity of it. This figure actually explains how the dynamic model of shrinking baby lung is evolved. So initially it was thought that it's an anatomically baby lung, where you thought that the dorsal portions are stiff ground glass appearance on radiological evaluation, and only the other part is a baby lung. But now when you started putting more patients on prone ventilation, you realize that the baby lung portion shifts sides, and the it is not an anatomical concept, it is a functional baby lung. Okay, so now what we understand during the COVID times, the baby lung and COVID-19 era, as the pathology progresses, you can find a shrinking baby lung in the dynamic model. So that is the evolution of the concept of baby lung. So even if somebody is a 6 foot high tall patient, his lung may be the functional lung remaining after an ARDS insult may be equivalent to maybe as baby size lung. That is an important concept. And now we go to the theater once again. As anesthesiologist, I would concentrate on that part in this lecture. This prophylactic perioperative positive pressure ventilation. It's a multifaceted bundle of prophylactic perioperative positive pressure ventilation. Okay, what you do here is right from the preoperative pre-oxygenation, you try to have a lung protective strategy in your clinical planning. So you can think of incorporating pressure support ventilation plus PEEP or addition of CPAP devices even in the preoperative pre-oxygenation, especially if you are handling a morbid obese patient or a high-risk patient. The category will come to that in a little while. And the prophylactic perioperative positive pressure ventilation should continue in the intraoperative ventilation as well. You can target lower tidal volume, 6 to 8 mL per kg of predicted body weight. You can apply positive end expiratory pressure, and in some cases like laparoscopic procedures, recruitment maneuvers are also are shown to help to avoid atelectasis trauma. When you extubate, you can still take the help of positive pressure ventilation like pressure support ventilation plus PEEP or CPAP devices to keep the lung protected in vulnerable population. Here also this concept is explained graphically, right from preoperative, pre-oxygenation phase to intraoperative until the postoperative phase. The target, the clinical strategy of lung protective ventilation will be beneficial. May not be in all cases, but definitely in selected patients. Okay, the future directions in perioperative lung protective strategies. You need to identify the high risk patients for postoperative pulmonary complications. So these are the categories, be it in a surgical category or anesthetic related category or patient related factors. You can identify the high risk category for postoperative pulmonary complications and implement the bundle of prophylactic perioperative positive pressure ventilation strategy. But still, there are some gray areas. There are literatures confirming or refuting the benefit of lung protective ventilation on a routine basis. So we need to identify the patient populations that could benefit them most. Elements of perioperative preventive positive pressure ventilation in patient schedule for non-abdominal surgical procedures need to be evaluated with further trials. And ultimately will boil down to a personalized, tailored approach. And after going through the literature, I would definitely say that it's only a question of time before lung protective ventilation become a standard of care in the perioperative anesthesiology practice. So I look forward to the your responses and queries on this topic during the Q&A session. Thank you very much for patient listening. It's me, Dr. Saneesh, signing off. Thank you.